Hi, good morning. I'm Kaitlyn Kelly. Our student, Kate Cho, that helped with this project was not able to make it to the meeting. And so I apologize for the late upload as well. But it's the green button here. All right. I have no disclosures. Cytoreductive surgery in HIPEC, or hyperthermic intraperitoneal chemotherapy, is associated with high rates of postoperative morbidity on the order of 33 to 63%, as well as high rates of readmission. Cytoreduction in HIPEC requires a large abdominal incision to allow for complete exposure of all peritoneal surfaces. An example of this, the typical HIPEC incision is shown in the image. For patients with low volume disease, however, a laparoscopic approach may be feasible and may result in reduced postoperative morbidity. The aim of this study was to evaluate the feasibility of minimally invasive cytoreduction in HIPEC in patients with peritoneal surface malignancy with a low volume of disease defined as a peritoneal carcinomatosis index of less than or equal to 10. We used a statistical design that called a balanced two-stage design, and we determined that a sample size of 18 patients accrued in 2 stages would be necessary to yield to provide power to detect a decrease in postoperative morbidity of 23%. Our study, this simple diagram here shows that we initially enrolled 34 patients or screened 34 patients and actually consented them. 16 were found to be ineligible, most often due to a higher disease burden than what was shown on their preoperative imaging. And then 18 patients went on to undergo laparoscopic cytoreduction in HIPEC. The peritoneal histology from the 18 trial patients is shown in the table here. This is from the histology at the cytoreduction procedure. In some cases, you'll see it towards the lower rows, it was benign disease, but in those cases, the patients were having HIPEC because they had undergone, for instance, an appendectomy that had had a perforated cancer. But there was no residual disease found at the time of the cytoreduction in HIPEC. But 9 patients had adenocarcinoma, and 2 had low-grade appendiceal mucinous neoplasm. 1 had low-grade carcinoma peritoni. The pictures here show in one of the low-grade mucinous neoplasm patients, the diaphragm covered with mucinous implants, and you can see the liver in the bottom portion of the image. And we are, laparoscopically able to mobilize the liver as the first step, and then can successfully strip the peritoneum. And in this case, we're using the harmonic for that. This table shows the baseline clinical and pathologic variables for the trial patients. And you can see that in most cases, including the adenocarcinoma, it was appendiceal primary. We see a high volume of that at our institution, even though it's a rare disease overall. The median operative time was 219 minutes, and these, for the continuous variables here, this is the median and the range, and for the categorical variables, is just N in percent. These are the postoperative variables for the trial patients. The median time to return of bowel function defined as first flatus was 3 days. The use of IV narcotics was 3 days, and length of stay median was 6 days. And in terms of complications, 3 patients for 16% had minor postoperative complications, grade 1 or 2, and no patients had major postoperative morbidity. And the picture here shows in contrast to the one I showed before, what the incisions are like when we do the laparoscopic perfusion. After this trial was done, because we met our predefined rate of acceptable postoperative morbidity, we went on to continue laparoscopic HIPEC for eligible patients. And this slide shows a few of the variables from a comparative analysis of these patients to historic controls from our own database of patients that had open cytoreduction in HIPEC, also for peritoneal, who had a carcinomatosis index of less than or equal to 10. And the groups, it's not shown in this slide, but they were similar in terms of disease histology and gender, BMI, all of the baseline factors. The carcinomatosis index was still higher in the open group on comparison, even though we limited it to people with 10 or less, which of course is going to show some selection bias because not everyone is eligible for laparoscopic approach. However, in comparing these groups, we still saw a statistically significant lower rate of lower estimated blood loss and length of stay, as well as lower inpatient morbidity. So in conclusion, minimally invasive cytoreduction in HIPEC was safe and feasible for highly selected patients. The screen failure rate was high, which is due to limitations in assessing disease burden with cross-sectional imaging. The median length of stay was 5 days for all patients, and when we went on to include all 22 patients. The inpatient morbidity rate was 17%, with complications of urinary tract infection, elevated LFTs, and ileus. So for patients with a PCI of less than or equal to 10, the laparoscopic approach was associated with less blood loss, lower morbidity, and shorter length of stay. Thank you.